Thank you very much, Adam, and welcome to everyone who's on the call today, and also to those people who are watching the recording, because I know how busy you can get and how busy we all are in general terms. I'm hoping that what I can give you today is a really good introduction to the webinar series, and we've made it into a series, firstly, because there are so many things that we can cover, and also because there is so much, it can be hard to take it all in. So this is the start, and I've broken things down a bit, as you'll see in due course, into bite-sized chunks for you, but also containing elements that you can put into practice straight away. There is some optional homework that you can look at, and it's designed not to force you to do it, but actually to give you a reflection point. And if you wanted to use these webinars as evidence for your appraisal, then doing the homework could actually enhance that. And certainly as an ex-appraiser, that's the kind of thinking and that's the kind of approach which is fantastic to see. I'm just going to go into my slide set, which means that I won't be able to see the chat, but Adam's keeping an eye on it. Please put your questions in there. I've also put my email address right at the beginning. So if you wanted to get in touch with me, I love talking to people about the things they've learned and about the questions they had and perhaps didn't get the opportunity to ask. So let's go into the slide set. And what I'm going to do is just start off with saying this is all about what cancer means to primary care. And this webinar series comes in part from my own experience being a GP, being a GP trainer, being a cancer lead, but it also comes from occupying regional and national roles, so that as well as seeing where we've come from and what it all means to us now, I also have a vision of where things are moving, which is pretty important, really. On the 4th of February, we're going to be having the release of the National Cancer Plan. And that matters because that's going to set the tone and the precedent for us as all clinicians through the NHS. A little bit about me to start off with, and I'm a retired partner. I'd been a partner for 25, 30 odd years at Measham Medical Unit, and for the majority of those, I was a GP trainer and educator. I have been until the middle of last year one of the primary care cancer leads in LLR, and now you're blessed with Stacey and Nikki as your cancer leads. In addition, I've also worked in London as a cancer lead for about 10 years, and I've been a Cancer Research UK GP for 10 years. The programme finished in October last year. So today I am an East Midlands primary care cancer lead, and my passions are for earlier cancer diagnosis. I love teaching and training, and so I train GP trainees as well as established GPs and other primary care clinicians. And I'm so invested in improving cancer detection. On the right-hand side, you can see some of the projects that I'm involved in. And so the PAN, for those of you that know what that is, that first top picture, that shows palm leaf together with betel nut. Sorry, could you mute your microphones, please?
Don't worry,
So
I've muted them for you.
thank you, thank you. So PAN, why does that matter in cancer? Well, PAN happens to be carcinogenic. The betel nut is a grade 1 WHO carcinogen in the same categories as asbestos and tobacco. And in Leicester, in Leicester City, we have a particular problem with mouth cancer that links into PAN, and I have a project around that. The second slide down is me demonstrating how to examine the mouth. And this relates to a project that I completed with Cancer Research UK called the Head and Neck and Mouth Cancer Toolkit. It sits on doctors.net. I'll come back to it, probably not today, but in a future webinar, just to show you what it contains. Because as a learning and teaching tool, it's very comprehensive. And in this particular sequence, I'm demonstrating how to examine the mouth in a thorough, systematic way, looking for signs of early mouth cancer. And the bottom picture is me talking about bowel screening and a project that we ran in Leicester City, where we created 3 different videos in Urdu, English, and Gujarati, all about how to do your bowel screen. And we tested within a practice to see whether sending the video out to people in their own preferred language made a difference. And it does make a small difference, but the numbers were small. But those videos actually sit on the ICB website if you do have a population that is predominantly Gujarati or have a real mixture. And I'll come back to that again when we talk about our screening in the second webinar. So the webinar series, today we're talking about what cancer means to primary care. In the second session, we're going to talk about cancer screening programs. And there was a really exciting update on Monday about bowel screening that I'll get you up to date with. In our final session, we're going to look at diagnostic tests in primary care and how we can use both routine and targeted cancer testing to improve the rate at which we diagnose and hopefully the stage at which our patients are getting diagnosed. Going into a little bit more detail of what we're going to cover today, I'm going to talk about the background of the rising incidence of cancer and then what our role is within primary care. And that, of course, links into recognition of red flags and of softer symptoms that our patients may present, and particularly combinations of symptoms. Then we'll move on to the NICE guidance on referrals, and I'm going to share with you the cancer maps, which is a tool developed by Ben Noble, who's a GP in Loughborough. So someone from within LLR has developed a nationally recognised way of understanding NICE guidance and applying it. We'll then move on to probably the best education tool there is, called Gateway C. And that's a cancer education portal, which is free and which is based up in Manchester. And I'll run you through why you might want to use this and use it to augment your learning and also personalize your learning. So if you have patients where you're reflecting and wondering what could have been different or wondering whether there are things that you're not up to date with, Gateway C is a really helpful tool for that. Finally, we'll move into how you can access and understand your own practice data, because to be honest, that's the data that matters most, because that's the population that we are dealing with, we are helping every single day. And by standing back and looking at your referral rates, your screening uptake rates, your new cancer diagnosis rates, that allows you to move beyond the day-to-day provision of care, provision of suspected cancer referrals, slightly further back and thinking about how are we doing? And then that allows you to compare with neighbouring practices. And I'll demonstrate how you can do that and look at your own PCN. And that leads into the homework, but of course that's optional, and we'll talk about that towards the end. So let's have a think about incidence data. And this is data from Macmillan, and they estimate that in England in 23, just over 350,000 new cancers every year. Now, if we take the UK, so of course that's Scotland, England, Northern Ireland, then it's 420,000. And that's 29,000 a month and nearly 1,000 new cancers diagnosed every single day. What we also know is that the incidence is rising. And if you look at the graphic on the right, first of all, these are the projections of numbers of cancers in an age standardized fashion. So you can see that the graph certainly is going up. And by the time that we get to the 2040s, it'll probably be near double, and that reflects an aging population. So if we go to the graph on the left, you can see that when we look at all cancers, the peak incidence, both in men and women, is those years between 70 and 80. And within that time, that's the time when we're thinking particularly about symptoms, where we're thinking where our background awareness should be significantly higher. Now, that represents just the overall picture, and it's divided up into men and women. So, men in that left hand graphic are light blue. So, at almost all ages after 60, men are outpacing women. But when you look in the middle of the graph, women are outpacing men in diagnosis of cancer. And that's because between 40 and 60, we're getting an increased incidence of breast cancers. And of course, in men, once we get beyond 60, 65, we're seeing that rise in prostate cancer. Now, one of the things that we all see as GPs now is that as well as having loads more people being diagnosed, that translates into more and more people living with cancer. So the latest set of data suggests that there are 3.5 million people living with cancer. So at Measham, we would have perhaps 80 new cancer diagnoses a year, but we had 500 to 600 people who were living with their cancer. So the other element is around how many people are dying of cancer. And it's nearly 170,000 people die with cancer on their death certificate, which we can take with a pinch of salt because of comorbidity, because we write the death certificates, and cancer may be one of the multiple elements contributing to that. But suffice it to say that there is a significant number of deaths relating to cancer too. The 3.5 million living with cancer tells us that the treatments and the stages at which we're diagnosing cancer have improved over time. And nowadays, treatments become far longer and there are far more options if you have a recurrence or if you need further treatment. So typically, for example, Herceptin treatment may last a number of years. So we've shifted from that having cancer, having the treatment, and then a year later being out of the treatment. That's no longer the way that things are. And we have treatments that last multi years up into the decades, and those treatments are continuing to develop. The top 20 cancers, if we think about that, this is divided up again into men and women, men being the lighter blue. And the top cancers, unsurprisingly, in women are breast and lung, in men, prostate and lung. And then the top four, which are the ones that I think are worth focusing on if you're going to look at your practice, are breast, prostate, lung, and bowel. So the other cancers all sit a little bit below that. And I'll talk a bit more about lung cancer for a couple of reasons. The first being that lung cancer is one of those cancers where the great majority, almost 70%, are diagnosed at stage 4. So the 1 year survival from lung cancer is dreadful. However, we do have a lung screening program, and I'll talk about that in the second webinar. And that's going to be starting in Leicester and Leicestershire this year, probably towards the end of the year. And that consists of asking ever smokers to come for a targeted low dose chest CT scan every 2 years from the age of 55 to 70. So I'm going to now dig a little bit deeper into bowel cancer. And there are a couple of reasons for this. One is that bowel cancer is the fourth cancer. I'll just go back up. It's the fourth commonest cancer after lung cancer. Nearly 40,000 people diagnosed in England and Wales. And the numbers who've presented with stage 1 or stage 2 cancer, in other words, the earlier stages, is improving. And part of the reason why it's improving is because of the hard work that you have been doing in primary care and the way that you have been applying the FIT test, the symptomatic FIT test, full blood counts, examination, appropriate rapid referral. That's the reason why we are improving those stage 1 and stage 2 cancers. However, if you look on the right-hand side, this snapshot, which is taken from the National Bowel Cancer Audit, the early onset colorectal cancer below 50 has risen, and it's risen by about a quarter in the last 2 years. Still, fortunately, small numbers. So we're going from something like 5.5% to 8% of all cancer diagnoses, but rising rapidly. And this complicated graph, I'm going to ask you to look at one thing only. This is data from America. And when it comes to cancer, the UK often follows America with the cancer trends. The line that I want you to look at is the red line. And the red line is deaths under 50 from colorectal cancer. And if you look at the red line at the beginning in 1990, it was the lowest cause of death under 50. And you track it to 2023, when it's overtaken breast, it's overtaken lung, and is now the commonest cause of death in the States under 50 from cancer. And that applies even when you age adjust that. So that second figure, B, on the right-hand side, again, colorectal cancer has hit the top of the under 50s and is continuing to rise. There's lots of speculation around why that should be, including being overweight, including insulin resistance, diabetes, the gut microbiome. Nobody has the full answer. But what we do see clearly is a problem. The other cancer that I wanted to highlight is lung cancer in non-smokers. And did you know that around 20% of all lung cancers arise in those people who haven't smoked? And the definition of a non-smoker is someone who's smoked less than 100 cigarettes in their lifetime. However, when we look at this number of people, if you think about it as being a cancer in its own right, it's the 8th most common cause of cancer death in the country. And this matters because it tells us that whether somebody has smoked or not shouldn't play a part in whether we investigate further. So if you have lungs, you can get lung cancer. A normal chest x-ray does not exclude cancer. And that's really important. It does mean that you've got a very low probability, but if you have a patient with persisting symptoms and a normal chest x-ray, you have to go on and take the next step and either arrange for a CT or arrange for them to be referred on the urgent suspected cancer pathway. I will come back to lung cancer later on in this talk. So let's just have a think. What do all those big figures mean? And how could that have any impact or meaning for us within our own practices? Here's a potential activity for you. And you may want to do it for yourself, or if you're a trainer, you might want to share it with your curious GP trainee who is perhaps looking for a QI project or wants to do an audit. You can search for new cancer diagnoses over the last 6 to 12 months, and often it can be a surprising thing that comes out. You can also look for people who are referred on the urgent suspected cancer pathways. And I'll show you how to do that. You can also look in greater detail at the primary care pathway, which is my next slide. And I've highlighted here a couple of resources, the underlined resources. When you get the slide set, if you just click on them, it'll take you through to it. And I've given a little example from the latest Joint Strategic Needs Analysis, a public health assessment in Leicester City. And what I've taken is Leicester data, and the arrow points out that lung cancer incidence in Leicester City is actually greater, the blue column, than in England, the green column. And isn't that interesting? Because we've got lung cancer screening coming in, but we've also got lots of non-smoking lung cancers picked up in that time. We undertook in 2024 a cancer awareness measure survey where we asked the general public what their understanding was about symptoms that could be cancer. And we had 1,300 people replying. And one of the things that stood out was that the general public really does not have a clear idea of when to come to see the doctor and which symptoms are necessarily those of cancer. And so there's something for us to have in our minds when we're seeing patients and when they're presenting, and we'll come back to that. When we think about primary care and the pathway, this is a model that we use to try and break down the intervals that we have. So when you look right at the bottom of those boxes, you'll understand all of this because this is our day-to-day work. Patients present with a symptom on the left for the first time, and then their first presentation is presented at the practice, and then we have an assessment period where we evaluate, investigate, and then ultimately, if we decide that patient has a high enough degree of suspicion, we refer into secondary care. And so you have these particular intervals, and you can see, of course, that these are just presented schematically. That first symptom is actually stretched out much longer. When we've conducted national audits, the average sort of wait time that patients have for significant cancer symptoms can be up to 6 months, depending on the cancer. And of course, there are intervals where we as doctors want to wait and see. We use time, as we always do, to see what's happening to symptoms. We safety net and bring people back. So all of these things contribute to the primary care interval. So this is a way of understanding. It's definitely not a way of judging whether you're performing in one way or another. It's a way of understanding. Then for us, when we've reflected on what's happening with our patients, to then see if there are any things that we could change. And I've done this activity looking at intervals with many practices, looking at their own data. And it's often led to particular ways of perhaps training for staff, for your reception staff, in terms of the questions they ask, or for ourselves as clinicians in being aware of different elements. For example, raised platelets, which 10 years ago wasn't an issue. Now, most of us know that raised platelets, especially if they are raised more than once across a month, they can indicate a risk of cancer. So when we move on to red flags, and this is taken from a Cancer Research UK page. So this is what we want our patients to be aware of. So this schematic just goes through, but on the right-hand side in that box, it's actually not a bad starting point for the general public around what to look for. And of course, as we look at those symptoms, we can see that each symptom just links through to one or two different cancers, but we would need more information, of course, wouldn't we? And so NICE last year produced an updated interactive guide. And when you get the slides, if you just click on the image, you'll be taken to that interactive PDF and you can go onto it and use it. So the way that you use it here is that you look at the category of symptoms, press on that, and it takes you through to the more detailed view. And so, for example, if you click on abdominal symptoms, this is the page that comes up. And on the right-hand side, you've got a set of columns linked to the NICE guidance, telling you what to do within 48 hours. If you do an urgent suspected cancer referral, that's what you do. And in the light blue, what are the investigations that are suggested within 2 weeks? And finally, other actions that you might consider undertaking based upon the NICE guidance. Now, the NICE guidance is pretty extensive, and the unfiltered NICE guidance is over 100 pages. And within it, there are pages within pages, and you can shortcut it and use CKS. So putting in CKS NICE takes you through to a summary of NICE guidance. What I'm going to show you is something that is visual. And this was developed by Ben Noble. This has been endorsed by NICE. So NICE feels that this contains all the information they have in their guideline. And Ben and his dad took the 100 pages of NICE guidance, the 400 pages of guidance behind that, and condensed it into a single page on a website. And I'll show you in a second how this works. So within this, this doesn't sit within System 1 or EMIS-Web. You have to have it up in a separate window, I'm afraid. But what I do, or what I did, was to have it open when I went into the practice because it was so good for just reassuring myself and the patient that we'd looked at their symptoms. And if you look just across the top, you can see that there's a little box where you can put the age of the patient, whether they're male or female. And then on the right-hand side, with the green background, patients come to us with symptoms. And what you're able to do is to tick the box containing the symptoms. And the advantage of this is that you can tick more than one box. So when you do that, that then works within those maps, those 3 maps that you can see. And the relevant bit of the map starts to flash red. Now, Ben has created a tutorial about this, and you can link into the tutorial on the website itself on that top right corner. When you go onto and through the maps, there are a number of things that you can do when you get into the map itself. There are little information icons, so the little blue circles, and if you click on that, you get a cut down set of information around background and risks for each cancer. So if you needed that or you wanted that information, it's all within the one tool. On the right-hand side is the full range of symptoms that NICE has highlighted within the guidance. When you go into the guidance itself, and here I'm just going into the pancreatic guidance, one of the other things that you get when you see the amber, so the amber round icons, is that it also gives you important information when you click on it about choices of investigation. So here, Ben has highlighted when you suspect that somebody has a pancreatic cancer, the guidance gives you a choice saying you can either arrange a 2-week CT or an ultrasound. But what Ben has done is link it into further information and pointed out, importantly, that an ultrasound has got a false negative of 30% compared with a CT false negative of 3%. So that gives you further information with which to base your next step. If you look on the right-hand side of the graphics, you can see that patients presenting with those sets of symptoms at the bottom, the nausea, vomiting, back pain, abdominal pain. If you have someone who's over 60 with weight loss and more than one of those symptoms, that's when you start to think about further investigation. But we also know, if you look towards the top of that diagram, that if you're over 40 and you present with painless jaundice, it's straight to urgent suspected cancer. One other thing that Ben has highlighted towards the left in the purple writing is Europac. And that's put in there because around the East Midlands, we are part of a European study looking at whether we can diagnose cancer, pancreatic cancer at an earlier stage and also within families. And that's called the Europac study. So if you click on that, that gives you information about it so that that may be relevant to refer your patient into the study. Let's test the maps because as GPs, we work with stories, we work with clinical encounters. So let me share with you something that we see not infrequently. Basically, there's a lot of it about. So a 42-year-old man presents with tired all the time, to the extent that he's fallen asleep a few times. He's sleeping as well as usual and doesn't have any obvious mental health issues underlying this change. And he's not quite as hungry as he used to be. No bowel symptoms and no urinary symptoms, no dyspnea or cough, and the examination is unremarkable. So when we take this not unusual presentation and we look at it through the lens of what could it be, one of the elements that this case illustrates is that lung cancer can present with non-specific symptoms. And if you look on the right-hand side, within the maps, if you have appetite loss and fatigue, our man is 42. So if you look in the middle at the bottom line, he's over 40. And in fact, he doesn't have a smoking history. So we go to the top line. He's over 40, no smoking history. And he's got two of the important symptoms, appetite loss and fatigue. And when you go to the left, the suggested action is an urgent chest x-ray. So this is important because it's broken down. And if you were to use the cancer maps and you'd put those symptoms in, this would have lit up. But it's broken down and reconnected the symptoms with the actions that you need to take. So when we think about lung cancer, third most common cancer in the UK and a bit commoner in Leicester City than it is in England as a whole. The commonest cause of cancer deaths, 98% of the cases are diagnosed over 50. So our man who's 42, he'll be very unlucky indeed to have lung cancer, but it needs to be excluded. A key statistic is that a third are still being diagnosed as emergencies. And these are the patients who become acutely short of breath and present to A&E. 5-year survival. At stage 1, in other words, at the early stages of cancer, really good, 65%. And when lung cancer screening is introduced, it's built upon the data that we've got from a number of pilots in the country. And what we're finding is that the majority of lung cancers diagnosed through screening are in the stage 1 and 2. And what has been demonstrated is an actual shift now in terms of cancer diagnoses and also potential for survival. It's turned round the deprivation gradient where of course, we know that deprivation links with survival. And for lung cancer, that's especially so. With lung cancer screening, actually, it's pulling out those people in the most deprived communities and diagnosing them much earlier. So it's a real game changer, and you will hear more about it next webinar, but also during the year as it gets rolled out. Of course, the 5-year survival for stage 4 is only 5%. And what we know in that bottom right box is that smoking accounts for 72% of the case. So it's your non-smokers. Now, when I reflect upon what is it then, if it's not something, what is it that's causing the change? Genetics plays a part, but there's now increasing evidence that air pollution, and particularly if you live next to a major road, and the impact of the fumes, and there are particular sized particles that come out of diesel vehicles in particular that irritate the lining. So there is research being done currently on that, and the most remarkable set of papers published the year in 2024 on how they worked out what the cause was from air pollution. Just going back to the maps, this is what the map looks like in this worked example. So you can see, it's starting from the left, that there are two key options that NICE recommends: either a 2-week wait chest x-ray or a 2-week wait referral. And the 2-week wait referral, hemoptysis over 50 or a suspicious chest x-ray. So those are pretty straightforward in that respect. The 2-week chest x-ray is the one which carries more subtlety, and you have the over 40 cutoff, but look at the range of symptoms that are involved. And so, for example, an over 40-year-old with persisting thrombocytosis, yep, please get a chest x-ray, and so on. So this is why I feel that what Ben has created is so useful in helping us to make decisions and guiding us towards investigations and speed of investigations. The tool itself, the maps, have won the NICE award. They've also won an RCGP award and also won a British Computer Society award. So, please try them out. And the way to reach them is to just press on the image, or you can just go to Google and put in cancer maps, Gateway C, and that will take you there. Which then brings us on to Gateway C, which I've already highlighted as being an especially good tool for us to learn. And over 19,000 primary care professionals are already using this. It's free CPD courses, but much more, as I will demonstrate. So when it comes to Gateway C, they recognize that you can't just have an online course. We all learn in different ways, and we all have different blocks of time that we can put aside to learn. So on the left-hand side, you can see cancer keys, and cancer keys are the single side most important things that you need to know about a particular topic. And that has been summarized by GPs for GPs. In the middle, Rebecca and Sarah do a podcast, and they share their own experiences, plus have discussions with experts in particular site-specific areas, and talk about how you can diagnose cancer earlier, what their primary care experience is. They are about half an hour long. If you are so minded, you can listen to them when you're going back from work or whenever you want. On the right-hand side, you can see the link to the cancer maps. As well as those three, there are multiple other resources, including webinars. And this webinar was from last year. The webinar series this year, in mid-January, included head and neck cancers. And there are further webinars planned for the next few months. So if you are interested, please have a look. They're also all recorded, so you can catch up with them. signing up to Gateway C is an absolute piece of cake. All you do is to go into sign up and then just put in your first name, surname. That's it. Construct a password. It does ask you what your role is and whereabouts in the country you are. And that's relevant because they do cover Scotland and Wales as well. So they have to make sure that the guidance that you get is relevant to us in England. I mentioned the courses, and there are now over 20 courses, and they last about an hour, and they cover loads upon loads of things from acute leukemia, breast cancer recurrence, which is a really useful one to have because for all of us in all our practices, the majority number of people living with cancer will be women who have had breast cancer in the past. And one of their fears, and one of the things that we will see recurrently in our patients, is the breast cancer coming back. And so having that awareness is actually a really useful base skill, I think. Colorectal cancer is a very good one. As I say, there are lots, and I've just gone from A to C here. Others include using the FIT test, head and neck cancers, lung, etc. The managing physical effects one is also very useful because it uses our skills as GPs to understand what the what our patients are presenting once they've finished their treatment. So the physical effects that come from radiotherapy, chemotherapy, and surgery. And it also helps you to think through who they need to be referred back to, because the temptation is always to refer back into the 2-week wait pathway, into the urgent suspected cancer pathway. But sometimes there are other colleagues and other pathways that can be more relevant. The webinars, this is a selection of them. So again, an absolute library of resources. And I think if you take away nothing else from today, please sign up to Gateway C. Please try the cancer maps, because this is information that you can put into practice at your next surgery. And this is also very appraisal friendly. I'm going to move on now to our own data. And there is a particular online tool called Fingertips. And what I've done is typed into Google Cancer Fingertips England. And the other way that you can get to it is if you just click on this image when you get the slide set, it'll take you through to that website. And when you get there, you can go right down to your own practice level. And I've picked my practice just because I have an idea of the figures and because I can take you through and show you how I would compare it. So what Fingertips gives you is it gives you things like your QOF prevalence. That's the very first item down there. And then it also gives you, as the third item, the new cancer cases. And as you track across the columns, you can see that at Measham in 22-23, which is the latest data, we had 84 new cancer diagnoses. And then towards the right hand side, you can see that that actually sits in the normal range, in the sort of midpoint range for cancer detection. And that means that we're no different, no better, no worse in terms of incidence. And that's taking into account our age profile. So, for example, in the city, you may have a younger population. At Measham, we've got an older population with a greater proportion of over 60s. As you go down on the left-hand side, you can see the number of 2-week wait referrals that we made. So what you can see is we made 77 2-week wait referrals. And so that means that 7 cancers were diagnosed outside of the 2-week wait referral pathway. And we might want to look at those cancers and think, well, how many of those were emergencies, for example? And what we can do is just start to look through and see all of these things. So it starts to become a very interesting, very rich set of data. You can look at particular cancers, so breast, lower GI, um, and so on. You can also look at something called the detection rate, which is the fourth column down, which is the percentage of new cancers treated based on those as a proportion of those that went through on the 2-week wait. And ours was 62%, yours may be higher or lower. But at the same time, it's all really interesting because it's your data. And then when you click on any one of those lines on the left-hand side, you then go into being able to compare your information to your PCN. So this is our PCN, Northwest Leicestershire. And I've put a red arrow as to Measham Medical Unit. And what this has done is in some of the columns, it's standardized it so that it's not just that you're a small practice or a large practice, it's actually evened it out as a rate. So this is just the number of 2-week wait urgent suspected cancer referral, as we now call them. So we can see that, for example, Dr. Lewis's practice, for its size, referred more than we did. Fine. And that we were the third from bottom in terms of urgent suspected referrals. We can then look at, for example, the lower GI referrals and where did we sit in that. And again, you can start to compare where we are. And you can see, for example, that Castle Donington undertook significantly more to equate referrals than we did. And there's something to learn for us. Perhaps we're not referring enough, and for others, it may be that you're referring more, and you might want to reflect on how many you're referring and what your criteria are. So this is showing how just within this one publicly available tool, you can start to get a lot of information about the activity within your practice and about the different cancer types that you have and that are relevant. So just moving on to what I'm going to suggest as homework, and it's building upon what we've been looking at here. So looking at your own practice data, because that's the data that really matters to you, and perhaps comparing it. And then just thinking about either the types of cancer or the number of referrals. The cancer fingertips also includes screening data. So as a warm up to the next webinar, do you want to look at your screening data and just see how it compares with other practices in the PCN? Are there any differences? Anything that really stands out? And if you do have time, or if you have a willing trainee, what about looking for all new cancers over the last 6 months and saying, well, is there anything that does stand out for me? Were they diagnosed through the 2-week wait, through the urgent suspected pathway? Is there any commonality? Are we having lots of one thing and not another? So it is it can become a really interesting exercise. The next webinar is going to be on the 13th of February, same time, and we're going to cover cancer screening. And that picture, of course, is the bowel cancer screening kit, and we'll talk a fair bit about that next time. But what I want to do now is pause because we've got a few minutes now where we can have questions, or you can ask about other things that perhaps I haven't yet covered that are really on your mind. And I'm happy to take any questions. If you're going to ask a question, you can put your hand up. Very happy to take those questions. If you do put your hand up, please be prepared just to introduce yourself and say where you're from, just so that we've got some context, and we'll do that. And of course, if there are questions that I don't get round to answering, always very happy to reply to emails. So, Adam, anything that's come up in the chat?
Thank you, Pawad. Yeah, took the words out of my mouth. So that's the next 10 minutes or so for a nice bit of Q&A and bit of a general discussion. So in the chat, I know Parasti just wrote about radiology rejecting CT scans when we'd normally ask for them. So they'd give a response saying chest X-ray is normal. I've certainly had that as well, Pawan.
Yeah,
Any kind of thoughts, comments on that?
I think that if my feeling overall is that if, as a GP, you are concerned enough to request a chest X-ray followed by a CT because the symptoms are persisting, um, they should accept that. And within my practice, what I would do every now and again is actually ring them up and justify it. I'd usually get a duty radiologist and talk it through with them. Most of the time that they agreed to it. And one of the other things that you can do is, as radiology often do, is repeat the chest X-ray. And so if you're able to put, for example, in your details, this is the repeat chest X-ray after 6 weeks, patient is still symptomatic with X, Y, and Z, can we have a CT scan? That may help. But this does, of course, reflect the challenges that we have in capacity across the system. But we, as our patients advocate, have to keep pushing.
Yeah, Frosty, you've got your hand up, so obviously I don't know if you want to
Yeah,
just introduce
Oh,
yourself and
yes.
then
Oh,
just
thank you. Yes. Don't get me wrong. We did push in these two cases, and I think they were
yeah,
actually lung cancer. But it's just because even despite these new changes, it may be even more difficult now. But before, it's just difficult when we get blocked. Not that we're not going to push, but it
yeah,
just makes it so hard. You got to tick the right box. And, I don't like to
yeah,
fib on the forms. I like to be very honest, but you just
yeah,
have to keep pushing and pushing. And I wonder if there's a way that these new guidance can be incorporated so they can see we're not just ordering it
yeah,
because we're not sure what we're doing. There's persistent
yeah,
symptoms.
yeah. That's such a great point. And one of I can't well, the answer that I would give is, can I come back to this next time? Because we have the new cancer plan coming out on the 4th of February.
Oh, yes, of course. Yeah.
And the thing that I've had sight of some of the bits of it, and there is talk in there about making it easier for us to arrange investigations. So I will put that as one of the points that I'll come back to next time.
thank you. Asma's just made a comment as well. If we want to be better in catching cancers early, we need UHL to be on board. Sometimes they forget that we are as much experienced as their own consultants are.
Oh, absolutely right. And I think one of the there's a very interesting bit of research that originated from Denmark, but it's been replicated in England, which is showing that GP gut instinct is actually a really good marker for cancer, to the degree that on the non-site specific pathways, we include GP gut instinct. And one of the reassuring things for us who are more mature in practice is that the accuracy of GP gut instinct becomes greater the longer you've been in practice. So I think it's often um, very frustrating when you get someone within the team who that you're referring to who perhaps has less experience or doesn't appreciate that we are dealing with undifferentiated symptoms all the time, and that is our speciality. Um, I would say that we have very regular monthly meetings with UHL, talking about these things, and we have two cancer leads on that board at the moment who are always advocating for the role of primary care and for making sure that the pathways are working to the best of everyone's ability within resource constraints, unfortunately.
Thank you, Pawan. Obviously, I know we're making the recording available. There was a question about the slides, Pawan, if they'll be able to have them as well.
Absolutely. What I'll
Yeah,
do is I'll share a PDF of the slides because it's quite a big slide set. That will come out immediate. I will send that immediately to Rebecca, and she will share it to everyone who has been signed up today.
so I think that was everything in the chat. But honestly, are
Yeah.
there any questions, anything you want to ask? I mean, please feel free to raise your hands.
Mhm.
Make it nice and interactive. Any comments, questions?
I can see Kate has got her hand up.
And I think that
Kate.
was an applause from Kate.
Yeah. Oh, right.
Applause, so,
Um, The next session is on the 13th of February, so just before Valentine's Day. And it's going to be at the same time.
Yeah.
We are going to be talking about cancer screening. And that's where perhaps if you've had a little chance to look at your own data or reflected on what you know about cancer screening, because there may be because I will share with you some things that are not very widely known at all. And can I just have a little show of hands, if that's right? Are there any GPs or colleagues on the call who are over 50? And I'll put my hand up, or coming up to 50. Okay, right. That's excellent. Thank you. Because what I'm going to share with you next time is something that's highly relevant for bowel screening. And bowel screening is now starting from the age of 50. And the information that I will share with you, and this is a teaser for next time, is did you know that you can get the actual number from your bowel screen? And Paramjit, this is one for you then. Okay, so when you had your result back from the hub, what they will have said is there is no need for further investigations at this stage, but can you be aware of all of these symptoms? At the moment, your bowel screen has been screened at a level of 120 micrograms. Okay. But the thing that happens is that on Monday, it was announced that the cutoff is going to be changed to 80 micrograms. Because what they've realised is that to make England equalise with Scotland and with Wales, we need to lower the threshold for positivity. Now, for me, and I'm going to use me as an example, when I got my result back, I thought, hang on, this tells me I don't have more than 120. But what if it's 119 or what if it's 118? So if you ask the hub, if you ask the hub director, Caroline, just email them, then the thing you have to do, Paramjit, is you have to email them with your NHS number and date of birth and ask for the actual number. And they will email it back to you together with a paper copy. So that's an example of the kind of thing that you're going to get that they never tell you. There is nothing on the paperwork that tells you that you're entitled to it. But under freedom of information, you are entitled to that data. And if I ever have if ever I have a result that is between 80 and 120, I would want to have a full blood count. I'd want to have a ferritin. I'd want to flag it up to my GP, and I'd seriously consider, hold on a minute, I really want to consider having a colonoscopy, because what if it is a polyp and they remove it 3 years before it becomes cancerous? That's a result. So this is the kind of thing that I'm going to talk about next time. So it's going to be a mixture of practical things that are relevant. And for those of us who are lucky enough to be under 50, think about it for your parents. I'll leave it there, Adam, because I can see that we've come up to time.
I think there was just one question. Sorry, just the last one from Anita.
Yep.
Anita, did you want to unmute yourself and ask this question? Sorry, if you can.
There is a difference between the fit test numbers when we do a screening versus when a GP requests, when we tell our patients do the fit test. And why is there a difference? Why is the one requested by GP more sensitive?
Okay. The reason is that the screening population have no symptoms, almost by definition. Okay. The population where we're requesting the fit kit are people who have presented to us with symptoms or signs that have shifted our suspicion to it being cancer, and we want to exclude cancer. So we're looking at two very different populations. And just to give an illustration of that, the way that the UHL pathway works is that if you test somebody with a FIT test because they have symptoms and the result is greater than 100, when you refer the patient in, that patient goes pretty well immediately to colonoscopy. That's because for that population, for this set of people, then we're dealing with a different range of suspicion. So that's why we cut off at 10 rather than cutting off at 120. You can make a strong argument. And in fact, in Australia, the cutoff for their bowel screen is 20. It's not 120. So you can make an argument on the resource capacity of your health system. So in Australia, they've got loads of colonoscopy capacity compared with England, which is why you have that difference between them. And I can see that the screening and I think Asma has pointed out, the screening population is at risk of being missed due to low threshold of values. Absolutely right, Asma. And next time, I'm going to use the bowel screening system's own data to show you why that is and how you can mitigate it on a personal and a professional level. So really important. And if you have, I'd love, this information to be shared far and wide. So if you do have colleagues who have an interest or perhaps want to know more about screening, tell them about the next webinar, because I'm going to talk about things that nobody else will actually tell you. So, for example, when I speak to hub directors nationally, they tell me that the number of people who ask for their own number, in a year, it'll be fingers of both hands, tops, out of hundreds of thousands of tests they've done. People don't know about it, but we as GPs, let's look after ourselves. Let's look after ourselves and our families, and make sure that we do that. Asma.
Hi, Pawan. Thank you so much. Very informative. Just wanted to, it's just an information.
Yep.
I'm the PD for Watermead PCN in Charnwood. Yep. And my practice, my PCN is taking part in the pancreatic cancer case finding.
Yep.
So it's hard work, a lot of work. Yes. But we are probably one of the in pilot in first group of doing it, and probably it will be extended. So just wanted to let you know that we are part of this.
Yeah. Thank you, Asma, and thank you for your contribution. I think it's through engagement with GPs like yourself and practices like yours that we're able to make the advances that we can. So once again, thank you for taking part in what is going to turn out to be a really significant, important trial. And this is so important because pancreatic cancer, and all of us are likely to have had our own heart sink patients where they come in with painless jaundice over 40, or they've been seeing us with vague symptoms over a number of months before the penny drops for us that it could be something like that. And I think that work that you're involved in is going to shift the dial for so many patients potentially.
Yeah, thank you.
This is just to let you know, this is for a newly diagnosed diabetics age 60 and above. Thanks.
That's right. Thank you.
Brilliant. Well, listen, thank you. I know we've overrun by just a couple of minutes, but thank you, Pawan, for a fantastic talk. Really look forward to part 2 and part 3, of course. And thank you all for attending as well and engaging. If we could ask you to kindly complete the feedback form. I know a couple who've left already, but Rebecca has put it in the chat and we'll be sending it out very shortly for everybody to complete. But otherwise, I hope you all have a good rest of the day and weekend, and I look forward to seeing you at the next Training Hub CPD event.